Okay, welcome back to Vet Wrap. Today we're going to talk about post-operative infection. Across from me is Nikki, all things amazing in the surgical nursing team, official title,
Senior surgical nurse.
Thank you, should know that. Anyways, Nick, I've dragged you in because, you basically help me stop my dogs get post-op infections and do stuff that I sort of just step aside and let it happen. Thank you for that. So we've been here before. Everybody who does a lot of surgery ends up with a concern over post-op infection rates.
Yes.
A couple of years ago.
Yep.
And so the thing that I want you to share is what was the reaction? What did everybody do when Al and I started saying, we're seeing a few post-op T-pillow infections. We need to have a think about this.
We really sort of took a step back and had a look at how we do everything.
Yeah.
Did
we do that at the beginning?
A bit of a panic station at the beginning. You hear that infection word and it sort of sends everybody into a bit of a panic initially.
Yeah, and then you find a nurse under the cupboard swabbing the sink. And you're like, What are you doing? It's true,
it's
isn't
going
it?
a little bit over the top.
Yeah, or like recalculating dilutions on heavy scrub, or it's like find the bug game.
Yes,
isn't it?
Going a little bit too far with your search.
Yeah. So and I've done surgery for a long time, so I've had to go through the cycle of identifying increased post-operative infection rates in a hospital, and then the process of working it out. And every time it's been the same. People get really focused on one aspect of infection control, and then they look at that and then they move on to the next bit. They can't, or they struggle to step back and go, hang on a second. So should I ask you why you need to step back, or should I talk about that?
I guess it's going back to the basics.
Yeah.
Reminding each other, are you washing your hands in between each patient?
Yeah.
Are we using hand sanitizer between each patient? Are we wearing gloves when we can? Just those very basic hand sanitizing that can get overlooked when we're taking in this big picture.
Yeah. So you just went to the end of the podcast for me. That's a wrap, we're done.
It's home time.
Okay, I'm going to talk a little bit. So I sort of scribbled some stuff down here that I showed you before. But first of all, post-op infection is one component of hospital-acquired or nosocomial infection. And that concept is you're a patient that went in for a problem, you didn't have an infection, and you leave the hospital with an infection. Yeah. So that's the other thing. People forget that post-operative infection is just not something that's isolated to the surgical team. It's part of hospital-acquired infection.
Yeah.
So therefore, first tip, look at the whole hospital. But the other part is that it's not a simple interaction between the bacteria and the patient. So your risk of a hospital-acquired infection is what type of organism you're infected with. So some organisms are very virulent, so you need very small numbers, you'll get an infection. Others, you can have higher numbers and you won't get an infection.
Yeah.
It's dependent on you as a patient, how healthy you are. In the case of surgery, it's dependent on, and say a traumatic wound, it's a case of how the local tissue health. So if you have a whole lot of necrotic tissue, you're more likely to get an infection.
Yeah.
And then the big one, the hospital environment, so infection control. Yeah, and that's why we always have to look at the big picture. Now, if I turn the page, here we go. If we talk more about post-op infection, then there's essentially 6 parts. It's preparation of the patient, preparation of the team, sterilisation of instruments, the operating facility, the surgeon's surgical technique, and then post-op care.
Yeah.
And all these factors are either reducing the potential for contamination in the surgical wound or making it such that the patient has a better chance of clearing the contamination they receive. Because every surgery is contaminated, but contamination is different to infection. Contamination is bugs falling in the wound. Infection is bugs actively multiplying in the tissue. So we had that, we're worried we might have an increased post-op infection. We stepped back and we reviewed. So if we start with preparation of the patient, what do we have to look at? Because that's your thing.
Yeah. We need to make sure that we're following our clinic. We try and make our own protocols so everyone is aware of what we're doing and everyone is doing the same thing. So there's no just sort of making it up as you go along, or I think we do that, I think we do this.
Yeah.
We review our protocols, we make sure they're up to date and that everybody's aware of them. First step.
Yep. Okay. So does it matter specifically which antiseptic you used?
Yes.
Do you think it does?
Yes.
Yeah. Okay. All right.
In terms of some can have the opposite effect on each other.
Okay.
We don't want to be using iodine and using a chlorhex or a metho. We want to be using them separately.
Yeah. Okay.
So we need to be aware of what we can use in conjunction.
But could I have a regime of iodine and alcohol versus chlorhexidine and alcohol? Just don't cross the paths, but
I suppose depending on what wound you're treating as well.
Okay. Yeah. So an open wound.
Open wound or around eyes.
You tend to go with iodine.
Yep.
Yeah. Okay. So what you did say then is you need to make sure the whole team's aligned and following your protocols.
Yes.
You obviously need to develop your protocols so they're appropriate for the products that you use.
Yep.
Yeah. What about just, the clips, for example, and how we do those?
Same thing. Everybody needs to be on board on how we're clipping our patients.
Yeah.
In terms of we're using brand new clipper blades, for instance, we want to make sure we haven't just picked up some clippers that have been used to treat, clip up a horrible abscess and now we're clipping our TPLO patient with those dirty clipper blades. So we need to make sure we're using clean clipper blades, clean clippers.
Yeah. And we pretty well have a protocol of new set of clippers per patient.
Yeah.
Yeah, cool.
And everyone's obviously aware of how to clip the fur so we're not irritating the skin because that's going to be causing more of a negative effect as well.
Yeah.
So clipping with the fur, then against the fur, everyone's aware of keeping an eye that the clipper blades aren't getting too hot. Just again, going back to basics on how to clip a patient.
Yeah. So you're a senior nurse, so one of your jobs is to quality control.
Yeah.
Keep an eye on people. So how do you actually get what's needed to be done delivered? So even like how do you stop people cutting corners on contact time?
I think we are quite repetitive in our little surgical world, and we make sure that we're working in pairs. We're working together with somebody. One nurse obviously doing anaesthesia, one nurse doing prep, and we have got again our protocols in place, and we've also got our training checklists that are triple checked off by a couple of senior nurses and our team leader, and it's really reiterated the importance of that contact time of the chlorhexidine. That step by step is very important. Yeah.
So what I've noticed over the years, sometimes a new nurse comes in and they may have had a different protocol.
Yeah.
And they're very adamant that the different protocol is better.
Yeah.
Is it better or just different? It's just different.
Yeah.
So
this is just how we do it.
Yeah, exactly. So that, I guess that's part of it too, isn't it? So building your team and an understanding, okay, you've read a paper and someone else did this differently, but that's okay if we all adopt the new different, but we can't half adopt.
Yes.
Yeah. So it's getting that unified approach to the process.
Yeah.
All right. So what have I missed on patient prep? Anything? Just big broad clips.
Yeah.
Appropriate use of clippers.
Yeah.
Appropriate contact times of appropriate agents.
Yes. Yeah.
What are our agents? What's our protocol?
So we do a 5-minute contact time of our chlorhexidine. Once that's had its 5 minutes contact time, we use an isopropyl alcohol wipe.
Yeah.
And then we go back to an isopropyl alcohol on top of that, followed by a final step of a chlorhexidine alcohol spray in theatre. So it's a 4-step.
Yeah. So what gets done outside the contact?
The chlorhexidine contact time of 5 minutes.
Yeah.
And then because we are doing our local nerve blocks, we want the skin to be clean for that. We then do our isopropyl on top of that.
And then into theatre?
Into theatre where we do another chlorhexidine wipe and then a chlorhexidine spray.
Okay. All right. So that's got the patient prep covered.
Yes.
So preparation of the surgical team. So that's my bit, I guess.
Yeah.
and it's the same conversation repeated, really. It's making sure that there's different ways of doing the same thing, that people understand the choices they're making. So we've gone to alcohol-based rubs, and ultimately, depending on the brand of the product you use, you need to be aware of the contact time. So ours is 90 seconds, however, it's getting new people coming in understanding that alcohol rubs are fantastic, but you still need to wash your hands with a neutral soap to remove organic debris.
Yeah.
And that you don't need to do a chlorhexidine scrub and then an alcohol soak. Don't mix two worlds as such.
Yeah.
Because what people don't realise is that the chlorhexidine-based soaps are an alkaline, rather than a neutral. You want a neutral soap, by the way. I got that wrong earlier, but hey, you are an alkaline-based soap, and that actually starts to strip the natural oils out of your skin, and so your skin barrier is not as good, so you're more likely to have pathogenic organisms on your hands. Okay, chlorhexidine is antiseptic, but the use of alcohol soaks is better for your hand health, and hence potentially as a surgeon you're less likely to have pathogenic bugs on your hands, because surgeons often have nasty bugs on their hands because we use chlorhexidine every day because we're prepping every day. We're sort of selecting for it. So it doesn't make sense to go and do a chlorhexidine hand prep and then do an alcohol hand prep. It's like you're sort of misunderstanding the process. Two is not better than one, but you do need to remove the organic debris. So we sort of have the same problem though in how do you get people to be compliant, because if you're doing chlorhexidine, you should have 4-minute contact time.
Yeah.
Which is actually why the alcohol rubs are sometimes better, because the shorter contact times, better compliance.
Yes. Yeah.
So, we have students as well, so we have to educate them on that side of things. Preparation of the team is also gowning. We've and that can be tricky too, can't it? Because we have a bit of a space limitation.
Yes.
So we choose to gown in theatre, and we have to sometimes stagger the people coming in to gown up because of space. So that those sort of physical attributes of your hospital can influence where you gown, and then obviously you guys do. We put the gown on, you tie us in, and then we're done. So that's sort of easy. Most people know that bit. Okay, sterilisation room, not your number one place, but
no.
But I guess what are some of the principles there as well?
Yeah, I think the sterilisation room is one of the most important places for everything to take place. It's very important that anyone that goes in there knows what they're doing in terms of cleaning the kit and the different sterilisation methods that we have. So obviously the first step, making sure that the instruments are clean and up to standard and in good quality as well, making sure they're looked after and not damaged. And then going to our two different means of sterilising. So we've got our plasma steriliser and our steam steriliser, and then being aware of the different indicators used for each and making sure something that's not sterilised doesn't make its way out into our kit area.
So you have a process of what comes in, how it comes in and how it flows out again. Okay. There's also some of those basics though with new people is how to load a steam autoclave, depending on if it's if a vacuum assisted or gravity displacement. Don't overload it. That's a common one, isn't it?
Yeah,
how
definitely.
to stack the packs vertically rather than horizontally. It's using the appropriate program, depending if it's instrumentation or cloth. Not that we use cloth, but if it was. It's also understanding that the gas plasma we use for arthroscopy and electrical drills, because of the lower temperature, so it is kinder to those instrumentation, whereas the hotter steam sterilisation tends to, over time break your scopes and break your drills. It's also training people to turn the machine on and use it and understand it.
And doing the machine's checks in the morning, making sure that they're all up to standard as well. And I guess everything that goes into our kits is new. We use brand new drape packs. We're not washing anything and then putting it through. All our hand towels, everything is brand new as well.
Okay. That, obviously we're talking in generalisations because a podcast on our gas plasma machine would be pretty dull.
Some people might find it interesting.
But it is that whole training theme keeps coming through, doesn't it?
Always.
You sort of have to understand the facility that you have, make sure that the approach you're using is appropriate for the equipment or the situation, and then get that training in place. So we have the kit Bible, don't we?
Yes, we do.
Which is every single kit.
Gospel.
The gospel. Everything kit we have in the place is documented, photographed,
Yes.
just how you put it together.
And updated.
Yeah.
How everything's packed, what goes in each kit.
Yeah.
How to look after it.
Yeah, exactly. All right. What about operating facilities? Because you were talking earlier about disinfectants, and I'd overlooked that. So
yeah, it's making sure anything that we use in terms of our disinfectants, they're not in multi-use containers. In terms of we're not just filling up our disinfectant and topping it up when it gets low.
Yeah.
We're using single-use containers.
So when you say containers, you mean from the bulk?
So say for instance, our chlorhexidine that we use for our scrubs come in these little, I think they're 500 ml bottles, and we use them to fill up our kidney dishes to do our scrub, and then when they're empty, they're gone.
They're gone to
heaven
with the bin.
Yes.
They're not reused.
We don't reuse them.
What's that about?
A lot of if these bottles aren't cleaned properly, if you are reusing them again, clean them properly. If they're just refilled, there's a high chance of bugs growing, and then you're using those.
Serratus is the big one.
Serratus.
That's the bad one, and Pseudomonas.
You're using these containers that have these bugs on them, tipping them onto your prep dishes, prepping your patients with a contaminated swab. So it's very important that that is one of those basics that is not overlooked.
And how do we get the dilutions right?
Those bottles wonderfully come pre-diluted for us.
Oh, okay. These are ones we buy. I'm talking about if you have a big store out the back. I see a big 20-litre drum of concentrate.
And dilute, we have a big dilution chart out the back.
Yeah.
It's very obvious, and that's got all your dilutions for everything in the hospital, from your mop buckets to your surgical prep.
Yeah. Because operating facilities sort of includes kennels and treatment areas.
And you've got different dilutions for different contacts. In terms of our isolation ward has a specific dilution for our stronger sort of stuff. And then you've just got your surface sprays that have different strengths again. So keeping an eye on those strengths.
Yeah, do you want to redo that? Time out, we'll do that. Don't worry about it. keeping an eye on those dilutions.
Yes, keeping an eye on those dilutions.
Yeah. So when we talk about operating facilities, what do we do in our theatres as a part of our hospital infection control?
Again, we love a protocol.
Yeah.
So we've got a protocol that, again, is made, every new staff member that comes on board is made aware of this protocol. And we like to do, again, step by step the same. And this is between patients. So if you've gone from one TPLO, you're about to put another surgery in that theatre, and at the end of the day. Yeah. So in between each patient, any bedding that they're on, towels or anything like that, is disposed of into the wash. Yeah. Every surface is sprayed. It has its appropriate contact time again. Yeah. It's very important.
What do we use for surface spray?
Otraven.
No.
Oxaver, sorry.
Oxaver goes up the nose of the brachy.
Oxaver.
Yeah.
And this is something that we recently actually changed from F10.
Yeah.
Something that we did a lot of research into, and that product sort of suited our hospital environment.
Okay, cool.
So that was recently sort of updated.
And that's another example. There's more than one choice.
Yes.
And you just have to go and research the products that you're looking at and work out the dilution that's appropriate for the circumstance, and is the circumstance you're using it in appropriate as well.
And again, it comes down to that contact time. Yeah. And this does have quite a sort of like a nice sort of small window of contact time, which is, again, more compliant.
Yeah. Yes, exactly. Because if it's too prolonged and it has to sit there 15 minutes.
Surgeons come out and they want to get their dogs into theatre.
Thanks for that. Anyway, that was a backhand slap to the head, but hey. All righty, cool. And the bedding side of things?
Bedding side of things is one patient, one use. So if the dog's been lying on a towel in theatre, then that towel's now in the wash. Yeah. And a fresh towel comes in for the next patient.
Yeah, okay.
And we also do full floor mop, everything gets cleaned in between theatre patients.
Okay. So we've managed 4 out of 6.
Not bad.
Yeah. So the other part, and I talked about it right at the beginning, is the local wound environment. So surgical technique, and certainly the more traumatic the surgery, the less preservation of anatomy, vascular supply, then the worse that local environment and the more chance of necrotic debris. So even things like overuse of electric cautery, leaving char in the wound, can predispose the patient to post-op infection. Because post-op infection and nosocomial infections are this relationship, as I've talked about, between the patient and the organism. The more virulent the organism, the harder for the patient to get rid of it. The less virulent the organism, the easier for the patient to get rid of it. The other diseases, if you are sick, you're not going to be able to get rid of that contamination. That ultimately, every incision has contamination in it. But if your health is not so good, you can't get rid of that contamination, and then it starts to multiply and become an infection. And the local wound environment, of course, impacts that, because if there's blood clots, char, devitalised tissue, well, you can't then, as a patient in its entirety, mount an appropriate response to the contamination and that big soup of blood and necrotic debris. Bugs like to multiply. So, of course, that's going to predispose you to infection. So good surgeons, less infection. Yeah. So, and then the last one, obviously, on that list is post-op care. And so what are some of the key things we're looking for when the patients come out of the theatre? What's it? I've sort of set you up here. Sorry. What are we checking?
Well, I guess from the second that surgery finishes, we're putting a little sticky Primapore cover over the wound as well, that's preventing external things, I guess.
Yeah.
And then making sure that their beds are clean.
Yeah.
And we've got appropriate cleaning between each patient of the run.
Yeah.
Again, fresh bedding for the patients, that they've got enough, adequate hospital checks. They're not sitting there lying in their own urine or anything like that.
Yeah.
And getting that appropriate hospital care post-op as well.
And there's the other thing where I was setting up is we're obsessed with bear huggers, aren't we?
We do love a good bear hugger.
So the science behind that is the quicker you can get your patient, or you, if you just had surgery, back to homeostasis, so normal temperature, normal blood pressure, the faster your immune system will come back into play and, again, clear up that contamination and stop it becoming infection. So if you leave a patient cold or you leave a patient hypertensive for a period of time after surgery, you're allowing the organisms that contaminated the surgical site to proliferate, and you're denying the patient a chance to get its immune system going and trying to actually clear that contamination.
Yeah.
So that care of the patient post-op goes just beyond just being hospital hygiene and cleanliness to actually get the patient back up and back to normal function as such. Yeah. So they're the sort of 6 aspects that feed into whether or not you'll get a post-op infection. So preparation of the patient, preparation of the team, sterilisation of instrumentation, management of your operating facilities, your surgical technique as the individual surgeon, and your post-op care.
Yep.
But we also, and you talked about hand hygiene. So the reality is, where does the infection come from? And it comes from us, doesn't it?
Yeah.
Transferring it from one patient to the next. I mean, here's the tricky thing. We never love this. What do we do when a patient has a non-multi-resistant organism?
There's a bit of panicking sometimes, all stations.
Wasn't thinking that. But what do we do with that patient?
Well, that's where I'm sort of going with the panicking, is it's easy to sort of look at that and be like, oh my gosh, well, we don't want this in our hospital.
Yeah.
But then looking at stepping it back again, is it's like all we need to do is be hygienic.
Yes, exactly.
And it's that simple of you don't need to panic when they come in the door.
But in reality, what do we physically do? We put them in isolation, don't we?
Yes, we do, yes.
Yeah, and it's nearly a contradiction, isn't it? Because we know this patient has MRSP on its skin historically, or had an MRSP post-op infection historically, or is still active and current. And so off it goes into the isolation ward, and then we dress up in a spaceman Mars suit, with gloves and plastic gowns and masks and hair hat. That works. It drives me nuts. And like we treat that poor pet as if it's a highly contagious beast.
Yeah.
But behind us in a cage, unbeknown to us, is probably another dog with an MRSP, because a certain percentage of patients have that on their skin anyway.
Yep.
MRSP being multi-resistant staph pseudointermedius. Yeah.
Yep.
So it's a slight
Yes, I agree with you.
Contradiction, isn't it?
Yep.
Yeah. So really what that sort of should remind us is if we are that focused on the dog that has a known multi-resistant organism and that's how we manage it, we should really be constantly thinking about how do we operate between the individual patients that are just our routines as such. And that comes back to hand hygiene and high level of hospital cleanliness.
Yeah.
So the other big one that I go on and on about is time.
Yes.
And so what's that in reference to?
In our, from the moment that our patients are, I guess from pre-med to recovery, we need to be conscious of the time.
Yep. And that's purely because the most consistent factor that has been demonstrated to influence post-operative infection risk is how long patients are under anaesthesia and surgical time. And there's a bunch of different numbers. I mean, there's a long list of risk factors for post-op infection. So, the health of the patient, if it has concurrent disease, makes sense because the immune system's not working appropriately. Sometimes things left of centre like the use of propofol, but that really is a reflection of hospital hygiene because multi-use propofol, the carrier, can be inoculated with organisms that will multiply. It's soy-based, I think it was. Use of skin staples, but that probably reflects the type of surgery, emergency surgeries, urgent surgeries, or or maybe it reflects skin closure, I'm not sure.
Yep.
Yeah. But really, so frequently it comes back to anaesthesia time and surgical time.
Yeah, yep.
So that's that. I always find that one slightly a struggle really with when I communicate to a nursing team because on one hand I'm saying follow the protocol, attention to detail, do the skin prep appropriately and precisely and don't shortcut contact times.
Yep.
But do it quick.
Yeah.
Yeah. And I know that you guys think that I'm just in a rush all the time and a pushy little bastard. Yeah. And I just want theatre to happen or surgery to happen. But the motivation there is efficiency.
Yes.
It helps keep our post-op infection rates within, the published ranges.
Yep.
And it is hard, isn't it? How do you keep your team super efficient but not cutting corners? Yeah.
I guess it also comes down to, again, everyone knows what they're doing. Everyone knows what their role is.
Yeah.
And that is if you're the prep nurse, you have these jobs, take the x-rays, clip the leg, prep the leg.
Yeah.
You don't have to worry about the anaesthetic. You're not worrying about any of that. So you've got your jobs, you've got your roles.
We're really big on that, aren't we? The allocation of roles and people being very aware of the expectation of each role and keeping people within their role, not drifting off into someone else's role.
And being just aware of the time you knock that dog out. It's in x-ray at 10 o'clock. You're keeping an eye on the clock, making sure you set yourself a goal of we want this dog in theatre at this time.
But at the same time, sticking to the protocol.
Sticking to your protocol, yeah.
Yeah, awesome. So, Nick, if we talk about infection control, we've just sort of had a conversation and cut it up into sections. And actually, for the audience behind the scenes, beforehand, I sat down with you and said we haven't prepared for this. And you were not happy. Sorry. And then I scribbled on a bit of paper because I just had to structure my thoughts. Because the issue is really, do we think about this specifically as we walk around the hospital? And when is it happening? It's like a continuum, isn't it?
All the time.
It's all the time.
Yeah.
And it's not even like, and I think maybe this happens to everyone. You have all these protocols in place and you've set them up and sometimes several years ago and you're doing them.
Yeah.
And then someone asks you, why do you do that? It actually can be hard to answer, can't it? You know why, you know that you should.
This is what I've been told to do. Yeah.
So it is, it's nearly intuitive what we do, isn't it? It's like we've set up protocols based on, sort of appropriate use of the product or the literature that's available or current techniques.
Yeah.
And we have that so deeply ingrained in the team that they just do that as their day-to-day job. But post-op infection or hospital hygiene to prevent hospital-acquired infections is a 24/7 job, isn't it?
Yes, definitely.
It's non-stop.
It's a constant part of nursing.
Yeah.
It's from the second you walk in, you're cleaning something or.
But it should be the vets too. We have to be thinking about it as well. Like the simple step of hand hygiene needs to become a habit.
Yes.
Like it's sort of awkward when you first start, isn't it?
Yeah, but now it's, we've got all the hand sanitizing stations. When you're walking along the wall, you're just sanitizing your hand. It just becomes a
reflex.
Yeah.
Yeah. No, it's good. So the other thing we do, Nick, of course, which you're not so involved in, is our hospital audit. So the interns we document every single surgery we do here, and then if there's a post-op complication, record that as well.
Yep.
And that's so that we can make sure that we stay within the published expectation of post-op infection, which is 1.5% for orthopedics and 3% for soft tissue surgical cases. And with TPLOs, they're a little bit higher actually. They're up to 5%, weirdly, just TPLOs, that's what they do. So we actually can see that we're drifting. I think that's something very much worth putting out there, is that if you have a high surgical load or volume, or hospital does a lot of surgery, you really should have an audit so you can tell that you're drifting away from those percentages before you have a crisis. And actually a couple of years ago, we didn't have a crisis, did we? We just had a bit of a shift, and we could see that our TPLOs were, I think it was 6%. And we're like, oh, that's not quite right. We need to do a review. So really in summary though, the big message about if you have a concern about your post-op infection percentages or rates and you feel they're climbing, is the very first thing to do is don't panic and don't look for a single answer, is it?
Yeah.
Remember, there's 6 different things that impact as to whether or not you'll develop post-op infection: patient prepper team, sterilisation, operating facility, how you manage that, surgical technique, post-op care, and then there's that relationship between the organism and the patient health versus virulence of organism, and that you have to just sort of stop. We pull the team together, don't we, and actually have a bit of a conversation and remind everyone of the importance of following the protocols, why we have the protocols in place. We review some of the protocols and make sure they're still valid.
Yeah.
Encourage hand hygiene constantly. Encourage people to be timely and efficient with processing of the patient to reduce anaesthesia times and surgical times.
Yeah.
The last one, and what I've completely glitched on before and we've come back to, how about the day of the year that we shut the hospital and clean the place?
It's one of my favourite days.
I didn't know you'd say that. But it's cool, isn't it? So it's actually something I'd put out there to other people, irrespective of whether or not you have a concern, is plan a day in the year that you essentially minimise how many patients you're going to see. We have an emergency team, so we're still open, of course.
Yeah.
And who gets involved in cleaning the hospital? Everybody. And it's cool, isn't it?
It's good.
Last time we had the practice manager driving around in one of those, like a lawnmower machine that cleans the floor. And we had the reception staff.
Yeah.
Everyone
was scrubbing.
Everybody, vertical and also vertical wall spells.
Yes.
Horizontal
it was
walls.
Great. We all got delegated a specific
and the place
area.
Looked really bright and alive.
Yeah.
We all walked into work the next day. It's like, oh my God,
sparkling.
It's sparkling. This is awesome. But that sense of ownership was fantastic too.
Yes.
It really reorientated everyone to the importance of infection control and all the little nuances and the steps that are involved in the process. So it was such a positive experience. And hey, I think we ended up at the pub at the end, so that's good too.
Extra bonus.
Yeah. All right, I think that's it. That's a wrap. And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.